All right, let's do this. All right, welcome to Orthostatic, a product of the Academy of Orthopedic Physical Therapy. I'm your host today, physical therapist Jimmy McKay. Today, we focus on a critical and often under-discussed area of physical therapy, the treatment of pelvic floor dysfunction and related conditions. Our guest, a highly skilled physical therapist at UW Health, specializing in the spine physical therapy, as well as pelvic floor disorders and women's health. She treats a wide range of issues, including musculoskeletal and joint problems, but also things that focus on the topic at hand. Please welcome Carrie Schwoerer. Carrie, welcome to the show.
Thanks for having me, Jimmy.
And before we hit record, you were live on the radio doing just this thing. We love when we see physical therapists out in the real world, right? When we talk to people in the community that can benefit from our insight, we like to say like the knowledge from our neck up, the things that we can do value-wise from our neck up. So thanks for doing that. And thanks for talking with us today.
Absolutely. Thanks for having me.
All right. And also before we hit record, you said, hey, listen, I could talk about this all day. And if someone looked at the topic and said, yeah, this is something I want to listen to, this is something I want to learn about, you are our expert. So how does women's health, which might be a different academy, right, a different component of APTA, how does women's health intersect with orthopedic physical therapy? When posed with that big picture question, where does your mind go?
Well, I think we oftentimes get really siloed, but we need to get some bridges between silos. So when it comes to women's health, we really have a lot of things going on. The basis is the bony skeleton. So bone health issues are such a big deal and that's also core to orthopedic physical therapy. But if I'm not considering age of my patient, where they are through their growth cycle, those are things that need to be considered, especially as people age and go toward menopause, women, that is. So that's one way it overlaps. Then if I think about pelvic health specifically, all of those muscles have synergies with the orthopedic, what we think of as the traditional orthopedic system. Sure. You need the pelvic floor to work with the diaphragm and the hip muscles and the low back and everything to get meaningful movement. So I'm not really ever just treating the pelvic floor, but I'm looking at the balance among those systems. And if you think about it, it's suspended right off the bottom of the pelvis, which we all think of as being orthopedic in nature. And then if we take it another step further in terms of pregnancy, there's lots of changes all over the body in terms of how loose ligaments may get during pregnancy. And if there's pre-existing conditions, there can be lots of pain that happens in that regard, but you're also dealing with a changing center of mass. So something to be kept in mind there. And then finally, I think about our oncology patients. So breast cancer is very prevalent in society, and urogynecological cancers also are in society as well. And oftentimes the fields that they do radiation with can impact the shoulder or the hip to a large extent. And even with some of our myeloma patients, they may have radiation done over their sternum, which is going to impact how the ribs move as well as the spine itself. So there's a lot of overlap that can happen. And of course, myeloma is not a women's health issue specifically, but it does tie together. So we have these silos of maybe we have the Academy of Pelvic Health and we have the Academy of Orthopedics and we have the Academy of Oncology, but there's so much crisscrossing that happens and all of that needs to be taken into account.
Yeah. So you're a physical therapist first, and you're taking the person in front of you into consideration, whatever that
absolutely
particular
and what their goals are, what they want to get out of it, because maybe they just want to be able to do everyday things, but we may have someone who wants to continue on with their sport. So we need to meet them where they're at.
Yeah. So let's get specific, right? That sounds like you set the table and you set the tone, good context. But what are some common orthopedic issues that might primarily affect women?
So osteoporosis with menopause is one that's a big deal. And I actually, with my orthopedic resident, do a clinic once a month where we see people who've had fractures. They are primarily women, and it is primarily postmenopausal women. So you really need to know how bone health changes over the course of the lifetime, and that there's that susceptibility immediately before, during, and after menopause. And there's an education component there to be sure. And I think we as PTs have the opportunity to come up with more classes and public health options. Since we know there may be a health shortage, we need to be a little more creative. So that's something I'm hoping to move toward in the future in my clinic. So there's your bone health piece of things. Then if we look at pregnancy, like that is one big old ball of wax. So there is a lot of neck, low back and pelvic girdle pain in pregnancy because there's so many changes happening. If we
Sure.
think about the fact that the center of mass is at approximately S2, in pregnancy, that center of mass moves anterior and superior. So there's always this changing, how are my muscles pulling on my joints? And for someone who maybe doesn't have coping skills, that can be challenging, or if they have previous low back pain or anything of that nature. When you come up to the neck, the diaphragm really gets pushed up, 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 up by that growing baby. So you can't get the expansion of the ribs. And now patients will start using their SCM and all of those accessory muscles, and that can develop into neck pain and headaches. So I see a fair amount of that as well. And really, it's something that I do as a women's health professional, but orthopedic PTs can do that as well. It just takes some creativity for how am I going to position them? I've got this big old basketball shape in the way, but we have a critical role there. And it doesn't stop at just the joint pain. We have increased fluid that's required during pregnancy to really take care of keeping a pregnancy going, keeping that baby safe. And unfortunately, it's not just in the belly that happens. It can happen in the neck and manifest as thoracic outlet syndrome. It can happen in the arms. So you may wind up with any of the peripheral nerves being a little bit impinged. Thigh numbness and tingling. Thankfully, the lateral femoral cutaneous nerve doesn't have a motor component, but you also can get foot with the tarsal tunnel. You can get some changes there. So all things that both women's health therapists as well as orthopedic therapists can all address those sorts of things.
Yeah.
And then when you get to the flip side, baby's been delivered, those abdominal muscles have stretched over 9 months. So they're not working optimally. So there's opportunities for neuromuscular re-education there, particularly if there's a diastasis rectus abdominis present, which is a splitting of the heads of the rectus abdominis muscle. And that just sort of leads to lessening of being able to generate force. And there's a lot of thoughts out there about how you best identify it, but it is one of the things that individuals come in with. And then that can bridge over to some of our incontinence issues and pain issues, which would be more continuing education to get really well versed in that area of things. And so those would be, we have our menopause, we have our prenatal, postpartum, and I go back to the cancer population again, because some of the specific things we see is with breast cancers, axillary syndrome, axillary cording can be one thing that comes out, and it really limits shoulder range of motion. So it's on our differential diagnosis list. Is this from the cancer, or is this patient in, age group and has comorbidities that this might be a frozen shoulder? We need to work through those things and meet their goals there. And certainly if there's been any sort of pelvic radiation, it can decrease the range of motion of the hip, which the pain might not be at the hip, it might be at the lumbar spine, or it might be in a different angle or a different area. And there's always the challenges with cancer of some of the chemo brain, so that fogginess and the fatigue. But with all of these populations, even though it sounds like, these are special, what do we do from a cardiovascular perspective? It all comes back to the American Heart Association's 40 minutes of moderate activity most days of the week. We just mix it up a little bit and maybe spread it out for, moms who are close to that delivering mark. They might be a little short of breath. We do that. We do the same thing with our oncology patients. And then we modify and use a rating of perceived exertion to be able to better manage where they're at with their symptoms. But I would say those are the biggest things I see. And I am not a lymphedema therapist, but if we talk about the cancer, there is also that piece of things. Sure. I have great colleagues that I refer to out for that, but sometimes there's still that orthopedic piece that needs to be done.
Yeah. So it sounds as if this is paying attention to the patient population, the person you're sitting in front of, understanding what things could commonly and do commonly happen to those types of people, and understanding what you as a physical therapist need to understand to get the most out of them in terms of education or intervention. So it sounds like it's really understanding is where it starts.
Understanding is where it starts. And I think a healthy dose of humility in all of us to say, this is what I know, and this is what I don't know. And if I'm not the person to help you, I will get you to the person that's more qualified.
Yeah.
With my patients who've had gynecological cancers, yes, I can do the pelvic health rehab, but if they also have a lower extremity lymphedema, I'm very clear to say that is not in my wheelhouse. But I have fantastic colleagues who are going to take care of you, and we're going to coordinate and make sure everything happens the way it's supposed to. So I do think we all want to help our patients, but we also need to be humble enough to say you're going to get better outcomes with someone else on this particular aspect.
You had touched on, physical therapy being able to address issues related to pregnancy and postpartum care. I feel like this is a good trend, is we're seeing more and more people be very, very vocal in our profession and outside of this being a need and not a want. This is not a nice to have. This should be a need to have.
It absolutely should be a need to have. If you think about that change in center of mass that occurs over 9 months, and then the muscles that get stretched in different ways, it's not like you deliver a baby and everything is this really perfect rubber band that goes back to normal. There are things that change. The ribs are not going to come back down after the diaphragm's been pushed up forever. And in terms of pelvic health dysfunction, yes, maybe it's okay for the first 4 to 6 weeks if you had a vaginal delivery and muscles got really stretched. Maybe some incontinence is normal there, but it should not go on for a prolonged period. And the sad part of it is most of the time the baby has, X day follow-up, 2-week follow-up, 1 month, and they have these check-in points. The person who delivered generally gets a 6-week follow-up, and it's mostly our tissues healed enough to participate in sexual activity again? And are you experiencing any symptoms of postpartum depression? And from my perspective, postpartum depression isn't always identified that early on. It can come on quite a bit later. And, they're not even necessarily screening for urinary symptoms. And I'm not saying everybody, because I'm sure there are physicians out there who are, but there are these needs. And the American Congress of Obstetrics and Gynecology actually published a position paper that they called the fourth trimester, which speaks to some of these things as they should be more mandatory and not a nice to have anymore. And we are way behind other countries in terms of our maternal care following delivery. Scandinavian countries, France, they have much better and more structured ways of doing this. So I would like to see in my lifetime a big switch to that being a standard screening. I mean, what's the harm in it? If everything's going well, you've at least had a check-in point, you have a baseline. But if something's not going well, you may be able to identify it soon versus it turning into this chronic low back pain that becomes more debilitating over the course of your kids growing up. And now you can't keep up with them. You can't do the activities with them that you'd like to. So if we could catch it early, it would be so much easier to treat versus letting it become a chronic condition.
Now, when we get our physical therapy license, we can treat almost anybody. But what specialized training do you think should be focused on the physical therapist working in women's health?
Well, I do think the physical therapist that's working in women's health, it sort of depends upon which niche they decide to go to. I started out my career thinking I was only going to do prenatal postpartum, and my first boss out of school said, well, you can do that if you also do incontinence. And I was like, well, postpartum women, they have that issue some of the time. So great, I'm going to do that. And then it turned into this other niche. And then once you start seeing pelvic health, it's sort of like drinking from the fire hose. If you're on the front end of it, they're like, ooh, we have someone who treats incontinence. And now you're getting men and you're getting, okay, you're incontinent, but you've had oncology things going on. So, we've developed over time. But if you're going to go more oncology, you would want coursework in that regard. Anybody who wants to work with women who are pregnant or postpartum, I think going to courses for that are really critical. And this is where we talk about the Cross Academy. I know the Academy of Pelvic Health has a certification program for that, but the Academy of Orthopedics has also had independent study courses for that. And that was actually the first independent study course I took out of school, was a women's health issue one that I think was 6 monographs, but it addressed the osteoporosis, the adolescent development pieces, and that helped guide me to branch out into some of those other areas as well. Yeah. So it's really figuring out, do you want to do overarching theme, or do you want to go in one specific direction? And that can guide it. But a solid basis of orthopedics is absolutely crucial, because I, said I was going to do women's health, and I was like, okay, I'm doing this, but I need to be better at the spine and the hips. So I actually came back and did an orthopedic residency, and I still practice my orthopedic skills every day. It's like you said earlier, I look at the person in front of me and say, okay, these are your concerns. This is what I'm seeing. How do we get to your goals? So I haven't buried any of those skills in any way, but it gives me an overarching ability to have those nuanced conversations.
Yeah. When you're talking about all these things, right? Statistics are great. We can throw statistics left and right. There's lots of them. You mentioned position paper. I'm sure it's full of statistics, but I want a story or two, an example of a success story or something that you came across that related to, hey, being able to combine these skills. Really, it's combined in your profession as a physical therapist, but being able to combine these skills in terms of women's health or pelvic health and orthopedics to get a really, really great outcome for a person. When I say that, what comes to mind?
I guess there's a number of women that I've seen over the years. I collaborate with my sports colleagues downstairs, and they have a running clinic where they'll look at, so sports, ortho, those things go together right away, but they'll actually do a running assessment, and they are trained in screening for pelvic health dysfunction. So they may say, okay, we don't think your hip pain is coming from your low back because you've had lots of PT for that and it hasn't gotten better. So let's have you do a pelvic health consult. So I've had a number of people who were having pain with running or having leaking during running or both that actually were able to complete marathons without having any leaking and without having the back pain. And like I said, that's more than one patient. I know you asked for a specific example, but that's more than one patient. Another patient that comes to mind is a patient who had quite a bit of low back pain, which wound up being SI joint dysfunction when I did all the clusters of testing. And she was a yoga instructor, pregnant with twins, and a high risk pregnancy. So we had to be a little careful with how we went along. And, we got her low back pain under control before delivery. Usually when I'm seeing someone prenatally, I'm proactive and I reach out to the referring provider because they're not real thrilled about direct access when there's another human on board. And I'll say, I would like to see this patient 6 weeks after delivery. Will you sign off on that? And they usually do. And I schedule them for, as we talked about earlier, more of that proactive piece of things. So she came back in. And she had to have a C-section because of twins. So we got her C-section scar taken care of, and she was back to instructing yoga by 10 weeks postpartum. And she didn't think that was anything she would be able to do just based on how quickly with the pregnancy, she wasn't able to do that. So she was just ecstatic to be able to do that in and of itself. And then this last example happened quite a long time ago, but it sticks with me because it was a little embarrassing. I was treating a patient who had pelvic floor pain since she delivered her son 25 years earlier. So she had not had sex in 25 years, and we got her to the point that she was able to do that. And it wasn't just her pelvic floor, it's her hips had gotten stiff and she wasn't mobile in her lumbar spine. So we got her a good exercise program besides the pelvic floor things, and discharged her. 6 months later, I see her in the Overture Center, which is our symphony building. And she comes running up to me and she's like, "Thank you. I've been able to have sex again," very loud. So there's all these people around that are staring at us like, oh my gosh, what does that woman do? And I was taken aback and I'm like, well, that's fantastic. I'm so happy that you've had those outcomes. And then my husband, who's beet red, is like, we need to find our seats. So that one sticks with me because he and I have a system now. If I see a patient or a past patient coming up, I kind of tug on my hair and he splits so that doesn't happen again, because I think he was more embarrassed than I was.
Yeah. I think that's just a testament to the impact that something like that can have. 25 years, that's not a small deal.
It's not, but a lot of women are told this is normal after pregnancy.
Sure.
So, you just deal with it. But that is not the case. And I'm glad over, the 20 or so years of my career that message is changing, because initially it was always, well, you just have to deal with it.
Right.
Wetting your pants after you have a baby, completely normal. Organs falling out, completely normal. Your back pain will go away within 4 to 6 weeks after, and it's 10 years down the line.
Right.
And they're like, I can't deal with this pain anymore. And I just say, well, when did it start? Well, during my, second or third pregnancy. So that story is changing gratefully. And there's not as much stigma attached to these things anymore either. I think we as a profession are doing a better job of saying, this is not normal. Like when the CrossFit video went viral that said, I lifted so much weight, I wet my pants. My colleagues in the Pelvic Health Academy were quick to respond to that and be like, that is not normal. That is not something we want happening. So I think we as a profession have taken bigger stances and more assertive stances on what is and is not normal. And I think we found these other venues, like what you do with your podcast, that resonate with people that we didn't have 20 years ago when it was mostly, the print sorts of things. So we have more vehicles by which to deliver our messages as well.
Yeah. Speaking about vehicles to deliver messages, you said one of the first resources that you used was an Academy of Orthopedic Physical Therapy resource. There's, just looking on their website, orthopt.org, in the independent study course section, the female athlete through the lifespan. That's a course right there, 32.2. What are some other resources you might recommend? Because if someone's still listening 20 minutes in, they're saying, okay, she's got me. I call it on the end of the diving board. She's got me on the end of the diving board. I'm ready to jump in. What are some things that you've found useful?
Well, I have found the Academy of Pelvic Health's courses for prenatal postpartum as well as pelvic health to be extremely, extremely beneficial. They do have certification programs, which when I went through, they weren't a thing. And I did not do the remedial work to get those certifications just because life happened with kids. But they are both excellent resources. Not to continue to stay completely with the APTA, Herman and Wallace also have an incredible and very similar certification program. And then both of those resources, I consider them to be very, very reputable resources. They have more niche topics too. Once you get past there, like there's some oncology and then there's male, and you can dive deeper into those sorts of things. I also think any course on menopause and how the hormones change and what it does to bone health, I think any therapist would benefit from that, because if you're not in women's health, you're probably still seeing the 50 plus subset.
Sure.
And it might be important to know, what you're dealing with, what changes may be happening there. So those are all incredible things. I love going to CSM and like picking off the menu, the buffet, so to speak, of all sorts of different things, because that helps to drive me into specific areas as well. But as you get into some of these niche areas, you can also, go into more oncology things. So I know sometimes my oncology colleagues will be like, okay, this association is doing this and PT registration is less than a physician's. Might you be interested? The ISHWISH, which is the Sexual Health Society, I've done some programming through there, because when you get into pelvic health, you have that really solid basis of lumbar and sacral spine. Crucial if you're going to be seeing prenatal, postpartum, and just getting some of the creativity of treatments in there. So there are so many options that are out there. I would just say if you are, an in-person learner, you're going to have those options. I'm a kinesthetic learner, so I really like those in-person things. But if you feel like you can get it from webinars, there's tons of those. There's melded learning. Again, 20 years ago, it was mostly you go in person or you do a read independent study, but now we have that melded version, which can help with defraying, cost of needing a hotel room for X number of nights, those sorts of things. But there are a lot of really smart PTs out there that I've learned from. I couldn't even begin to name all of them because I would inadvertently leave some of them off the list. But, connect with somebody who's interested. Shadow them if you have that opportunity, and get together a really robust group of people that want to talk about the same thing. We have journal clubs here for our pelvic health team, and in our orthopedic team we also will discuss new articles and things like that. So it doesn't always have to be the really formal. I think some formality is necessary, but if you get in there and you love it and you don't know where to go, just connect with people who are like-minded and are going to help you get those resources and help you when you get to a stuck point. Because even when we know the stuff, there might be a little twist on the patient that you haven't seen before.
Yeah.
And those are your best resources in those instances.
Yeah. Great advice. All right. Last thing we do on Orthostatic here is called words of wisdom. So what words of wisdom would you want to leave with the audience today? It can be a personal mantra, a soapbox statement. What would you want to wrap up with?
I would just say the day you want to stop learning is the day you should hang up being a physical therapist, because things are always changing. You know, that's the great thing about science and research and us learning more. So if you no longer have a desire to keep learning and pushing yourself to be the best you can be, it might be time to consider hanging up the hat. That might sound harsh, but
it's a great way to look at it, but challenges you to be a lifelong learner, which is a phrase we love to use in this profession. Carrie, appreciate your time. Thanks for coming on Orthostatic and sharing your knowledge.
Well, thank you for having me, Jimmy. This has been fun.